This respiratory lecture will examine malignancies of the lower airway, which includes lung cancer. Cancer of the lung can be either metastatic or primary. Metastatic tumors may follow malignancy anywhere in the body. Probably the most common places that they metastasize to are the colon, the kidneys, and that particular area. Metastases occur in about 90% of all patients with lung cancer and may occur to nearby structures such as lymph nodes, esophageal walls, the pericardium, or they can metastasize distantly to the brain, liver, kidneys, adrenals, or skeleton. Unfortunately, in 70% of lung cancer patients, the disease has already spread to the lymph system and other sites in the body by the time the diagnosis of lung cancer is made. It's the leading cause of cancer death in both men and women in the United States. It's definitely linked to cigarette smoking. It's the third most common type of cancer in the U.S. after breast cancer and prostate cancer. Only about 10 to 15% of people who develop lung cancer survive 5 years after the diagnosis. And there are many different types of lung cancer, which you can read through in your speaker notes. Signs and symptoms of lung cancer include a cough, shortness of breath, unilateral wheezing, which is present in about 20% of all lung cancer patients. Pain upon inspiration, friction rubs, and pleural effusions are noted. Patients may also exhibit edema of the face and neck, especially when the vena cava is involved, fatigue, clubbing of the fingers, and in later stages that patient may develop weight loss and debility, and also metastases to the liver. So those patients that have that persistent cough, especially combined with hemoptysis, anorexia, or a change in a chronic cough, need to be followed up in order to look and see if lung cancer is indeed their particular problem. Prevention strategies for lung cancer include smoking cessation programs and early intervention programs for patients once they are diagnosed. Probably the latest statistics show that about 25 to 27% of Americans do smoke, and it takes about 15 years for the risk factors of lung cancer of a former smoker to equal those of a non-smoker after that person does quit smoking. Smokers are 10 times more likely to develop lung cancer than non-smokers, and the risk associated with smoking increases with the number of years a person smokes. So we've talked before about pack year histories, so we look at the number of packs per day times the number of years that the person has smoked to look at their pack year history, and sometimes you'll see that noted in the patient's chart. Secondhand smoke also increases a person's likelihood of developing lung cancer. As a matter of fact, somebody who's exposed to secondhand smoke on a routine basis has a 34% higher chance for developing lung cancer. The nursing situation we're going to have for this particular lecture is a 56-year-old female admitted for elective right middle lobe and right lower lobe lobectomy. She's had a 60-pack year history of smoking, has had a dry persistent cough, and she's noted to have wheezing. This is a very common symptom, is that persistent cough or a change in a chronic cough for someone who does have lung cancer. Another common symptoms that is sometimes seen with patients is unresolved upper respiratory infections. They may also have chest or shoulder pain, blood-tinged sputum, and recurrent fevers. So unfortunately, lung cancer is sometimes asymptomatic until later in the stages of the lung cancer. Preoperative teaching for this patient having a lobectomy is going to be including letting the patient know it will be an ICU stay after this particular surgery. The patient will have chest tubes and an endotracheal tube in after the surgery. Once those are taken out, that patient's encouraged coughing and deep breathing exercises, use of an incentive spirometer, and range of motion to the postoperative arm so that that patient doesn't develop an ankylosis of that shoulder area. Also, nursing interventions will include monitoring vitals, oxygen, EKG, and the patient, if they have a Swan-Ganz catheter, monitoring what those readings are. So please see your textbook for additional information in this area. Surgical interventions include those listed here on this particular slide, depending on how small the area of the cancer is in the lung and if it's invaded any surrounding tissue. The patient may only have to have a segmentectomy, which is the first picture there where only a small segment of the lung tissue is taken. If a larger area of the lung is involved, the patient may need a lobectomy where an entire lung lobe is removed. And if that patient's cancer is pretty extensive throughout the lung, then that patient will require a pneumonectomy, which is a complete removal of the entire lung. So your speaker notes list further details on each of those different types of surgeries. This is just another viewpoint of a patient undergoing lung surgery, so you can see how extensive it is, and you can certainly understand why that patient would be sore after this particular surgery. So anytime the chest wall is opened up to get into the chest cavity, that's noted as a thoracotomy. So that particular slide examines that. Post-operative care for these patients that have had lung surgery will include frequent monitoring, trying to keep the airways open and to promote deep breathing, arm exercises, which we talked about earlier to prevent ankle or shoulder ankylosis, positioning the patient in the correct way, and also the patient will have chest tubes in if they had a segment of the lung removed or a lobe of the lung removed. So chest tube monitoring would be an important part of that patient's initial care also. For the patient that does come back with a chest tube in, this is a good depiction here of what the chest tube looks like. The pictures with the bottles below is showing pretty much a system that's not used too much anymore. When I was a nursing student, this was all that was available was a bottle system, and this was used as a chest tube measure. Now we have the units that you see there depicted on the right hand side, where actually we have portable Pleurovac units, which are nice because those are used for each patient and then disposed when that patient's done with that particular unit and those types of things. With the chest tube Pleurovac type of system that's there are different drainage systems within it. If you look at the first chamber there that's listed, the first three boxes that you see within that Pleurovac system, those are drainage collection chambers. So part of the nursing interventions would be at the end of each shift to note how much drainage that patient has had per shift and that type of a thing. Immediately post-op, it's not that uncommon for a patient to have 100 to 300 milliliters of bloody drainage out in that collection chamber for the first few hours post-op. Then that should start to dwindle down to about 50 milliliters per hour over the next few hours. And then as it gradually decreases and turns serous, then that patient probably doesn't have a need anymore once that lung is expanded and that type of a thing. The next chamber that you see there is the suction source or air chamber. And as you can see down at the bottom, that has a water-sealed chamber, which is kept usually at about 2 centimeters or so. You should only see fluctuations or very, very slight intermittent bubbling in this. You should not see any constant bubbling in the suction source. More what you're going to just see are gentle fluctuations with inspiration and expiration of the patient. The third column that's over to the right is actually the suction control chamber, and this is where you will see you will see bubbling if that patient is hooked up to suction. Typically it's filled to about a 20 centimeter water mark, and then when that patient's hooked up to a wall suction, that does prevent that negative pressure to help expand the lung and help to draw out fluid and things like that. So please refer to your textbook for further information on chest tubes. Also monitoring chest tubes includes knowing which system is being used to monitor the drainage amount and the color, which we talked about a little bit earlier, to look and see if there is bubbling and fluctuations in areas where it shouldn't be, to know what the physician orders are, and to make sure in an emergency situation that there are chest tube clamps at the head of the bed. The chest tube should never be clamped except in an extreme emergency. Typically, if it's disconnected, it's recommended to cut off the tip of the chest tube and insert it into sterile container and then reattach it onto the Pleurovac system. If the patient would be disconnected from the chest tube at the actual chest site, which would be a tough thing to do considering that that's sutured in there and everything, then in that case you would need to make sure that you had an occlusive type of a dressing over that immediately, as soon as that, if that would happen with that patient. Some other things that you would look for are to look at the actual chest tube site into the skin. It's not that uncommon to have a little bit of air escape into the skin and to be leave what we call sub-Q crepitus or sub-Q emphysema. So feel that skin that's actually around the chest tube insertion site, and check for air leaks from the pleural space also into the soft tissues. It'll almost feel like a Rice Krispie type of a feel in the skin if you're feeling some air leakage into that area. So also things that you should make sure that are checked to make sure that the drainage system doesn't get kinked, clamped, pinched, stretched, or anything like that. That can interfere with drainage. We typically don't milk the chest tubes. That used to be done more on a common basis with a special type of a device that would actually strip the chest tubes. We don't do that anymore unless there's a specific order to have that done. The reason it was done was it helped to get, if there were clots or different things like that in the chest tube, it would help to get them out. The person can be ambulatory with the chest tube. It's just very important that the pleurovac system is kept lower than the chest. Just the same as if you ambulated a patient with a Foley bag, you would keep the Foley bag lower than the site of the bladder. So same goes here with the chest tube site. And to check to make sure that that patient can come off of wall suction if the patient is going to ambulate around, that type of a thing. Charting for a patient with a chest tube would be to include that the patient, what type of system that they used, for example, pleurovac, how much suction there was. The picture that we looked at a few slides ago showed 20 centimeters of suction. The drainage, color, and amount the patient had out per shift, if there was bubbling, sub-Q crepitus noted, and the appearance of the dressing around the actually chest tube site. So typically when the chest tube is removed, the patient will have them perform a Valsalva maneuver, and then we'll apply a petroleum gauze dressing, and that gives it a non-porous seal at the actual chest tube site. Discharge teaching for patients that have had chest surgeries and pneumonectomies or lobectomies done would be to make sure that that patient is active when they get home. They will be very fatigued, so gradually increase activity levels, making sure that the patient keeps up their coughing and deep breathing exercises and incentive spirometer once they go home, and to follow up with those arm and shoulder exercises about 5 times per day. For pain, just oral analgesics are typically okay for these patients, and to avoid lifting more than 20 pounds for about 3 to 6 months after they've had this particular surgery done. And then obviously to get those patients enrolled into smoking cessation programs. For the patient that actually has an entire lung removed, which is the pneumonectomy, the care will be different because that patient will not require chest tubes to re-expand any portion of the lung because the entire lung was removed. And when we position this patient post-operatively, this patient can lie on their back or the operative side. We don't let the patient lie on their unoperated side because what that does is it puts pressure on the good lung, and we want to try and keep that good lung expanded as much as possible. The chest will actually fill up with body fluids and will fill the cavity where the lung was eventually. So the bronchial stump will just be what's left inside that patient. And that's how that works for the patient that's had the entire pneumonectomy done. So a good NCLEX question is, the nurse is caring for a client who's had a chest tube inserted and connected to a water-sealed drainage system. The nurse determines the drainage system is functioning correctly when which of the following is observed. So the correct answer there is fluctuation in the water seal chamber. Remember, gentle fluctuations are noted there, but you should not see real active bubbling going on in that particular area. The number 4 response was vesicular breath sounds are heard throughout the lung fields. That's true. Vesicular sounds are typically heard over that area, but that wasn't the best answer to answer what the question was asking for this particular question. This NCLEX question talks about a nurse entering the room of a client who's had a chest tube attached to a water-sealed drainage system, and notice that the chest tube is dislodged from the chest of the patient. So the most appropriate nursing intervention for this particular scenario is, we talked about earlier, number 3, cover the insertion site with a petroleum gauze. That will make an occlusive dressing, which does not allow the lung to deflate any more than it probably has from being disconnected from the chest tube area.